is Selvin. I'm the moderator for today's session on the AHA statements. And I'd like to start by going down the line here and asking our speakers to give a brief summary of each of the statements that they're covering today in today's session. So Seth, starting with you.
Absolutely. Thank you, Liz. So I am the chair of the EPI Statistics Committee, which produces the annual AHA Heart Disease and Stroke Statistics update covering U.S. and global data. So this is actually a new addition, global, to the title of our document, representing the increased inclusiveness and emphasis on global data. Our document is 567 pages long. So there's a lot of dense and important statistics in there. We have 30 chapters. We have a 44 person writing group, which I understand is the largest writing group of AHA. So really thankful to the entire writing group team, Sally Wong, Debbie Hurd, who as AHA staff really are at the heart of the document. So one of the key statistics we track, of course, is cardiovascular mortality. And that can be looked at in terms of absolute terms as well as age-adjusted rates. What we see is a bit of a positive signal in this past year, looking at the 2021 data, because over the past decade, there had been this increase in cardiovascular disease mortality. And there was a small increase, but it appears to be a slowdown compared to prior years. So there was about a 3,000 person absolute increase in cardiovascular deaths, which is quite small compared to more than 50,000 the prior year. And if we look at age-adjusted rates, it went up about 4% in 2021 compared to the prior year of data, which appears to be a slowdown compared to before. So we're hopeful that that will continue, and not only will we have a continued slowdown, but actually a reversal in cardiovascular disease mortality, which is what we had seen in prior decades, particularly in the 1980s and 1990s, when there was really tremendous progress made. So we're hoping in both absolute terms and age-adjusted rates to see continued progress in cardiovascular disease mortality. We'll be tracking that closely. But our document, as you can imagine, and you very well know, dives into all the aspects of cardiovascular health, cardiovascular disease. We've increasingly incorporated life's essential 8. We're updating the prevalence of cardiovascular risk factors. For example, hypertension, which affects over 122 million US adults. That's 47% of US adults. Chronic kidney disease affects 1 in 7 US adults. And of course, that's particularly important now that we understand the connections of kidney disease better with metabolic disease and cardiovascular disease as outlined in CKM. So there's tremendous wealth of statistics in our update. I encourage folks to interact with the document itself, but there's also a number of related materials, including infographics, fact sheets, including new global fact sheets. We found that there's from 1990 to 2021, the cardiovascular deaths has also increased substantially worldwide, now up to 19 million cardiovascular deaths worldwide. So there's a lot of really useful material, and it's really targeted at a wide audience for readership. And I'd like to just, again, thank our incredible writing group, Sally, Debbie, my Latha, who's the chair-elect, Evan Thacker, who's the chair of the EPI Stroke Statistics Committee. It's been a tremendous team effort. And we have really rich history to update. This is a document that, as we dug back into HA archives, has been updated dating back to 1927, when it was a single author publication by an amazing woman named Jessamine Healy, who we've learned loved heart disease stats, but also baseball and a number of other things. Was a truly amazing woman. So it's really interesting history, and you can learn more about that in some of the HA news articles that came out alongside our update. So, and I also just like to highlight that there's been tremendous progress over. We're looking at a year-to-year basis, and sometimes in shorter time windows. But if you look back at the progress, over the decades, what the statistics show is that smoking rates are way down, from over 40% to about 11% now. When someone has a heart attack, the mortality is way down overall cardiovascular disease mortality is down 60% from the 1950s. So there's been tremendous progress over the decades thanks to the efforts of the AHA, and I think that's important to kind of reflect on as we celebrate the 100th anniversary of AHA.
Well, what an undertaking. I look forward to reading all 364 pages. Alka, can you tell us a little bit about your scientific statement?
Sure. So I was part of the team that wrote the first epidemiology of diabetes and ASCVD in Asian American populations. And I just want to say that, Asian Americans are one of the fastest growing subpopulations in the United States, with a growth of about 40% between census 2010 and 2020. And this diverse population group has 23 countries of origin, and what we try to describe is what we know in terms of prevalence of diabetes and cardiovascular, both prevalence of disease and mortality. And it's a very heterogeneous picture. And part of the problem is we have lots of data deserts. We have gaps in knowledge. We know that the prevalence of diabetes is really high in some groups like Filipinos, South Asians, and relatively lower in East Asian populations, but there's many Southeast populations we really don't have good data in. For cardiovascular disease, in terms of prevalence, again, it's a really mixed picture, with some really high rates of CHD in Asian Indians and very low rates in East Asian populations. But then when you look at cerebrovascular disease, that's when the East Asian and Southeast Asians have much higher prevalence. We don't really have any incidence data, unfortunately, to really speak to. But what I think this tells us is that we have really great opportunities to understand why some groups may have high rates of heart disease, yet low rates of cerebrovascular disease, and some groups are the opposite, by really comparing different Asian American populations. And I'm just happy to be a part of a new cohort that's being launched by the NHLBI as well as other NIH institutes to actually study Asian Americans in a longitudinal prospective cohort study starting this year.
Really exciting. Yeah. Kiara?
So I chaired the statement on neighborhoods and cardiovascular health, and we really saw it in three parts. First, as a blueprint for any investigators who are interested in studying neighborhoods and cardiovascular health, thinking about how we define a neighborhood and how we measure what matters most. And then we get into the state of the science, and we look at observational studies. We also look at how neighborhoods have been integrated into healthcare systems, and different types of interventions and policies that have meant to modify the neighborhood environment. And then we end with future direction, so gaps that exist in the literature. And I think some of the biggest things that we found is that although the public health literature and epidemiologists suggest that multi-level interventions will have a high potential, there just still aren't a lot of studies on multi-level interventions and their impact on cardiovascular health. So that's a big gap in the literature. And then also we need more community-based, community-centered, community-led work to be done to really improve the sustainability of the efforts that we're trying to pursue around neighborhoods of health.
Kevin?
I was the lead of the Presidential Advisory on Food as Medicine that a group of us wrote on behalf of the AHA's Healthcare by Food initiative. I want to give a shout out to my vice chairs, Srila Sharma and Seth Berkowitz, as well as Jen Muse from AHA staff, who played such a pivotal role in making this happen. In essence, what we tried to do in this presidential advisory is take stock of what is known about the field. There are a lot of existing gaps in the literature. There's very few trials that have been done. And we critically assess that and then provide a pathway for thinking about how to build evidence on what's effective, what's cost effective, all with a goal towards convincing public and private payers to cover these programs. And that, I think that evidence summary was a really critical part of the article, but a lot of it was also thinking more broadly about the strategy for what the field needs in terms of building evidence and building partnerships, and really thinking about elements like human-centered design and how they can be helpful in terms of increasing engagement rates with these programs and making them more user-centric for our patients.
Excellent. So maybe starting with you, Kevin, tell us, I want to hear what it's like to serve on these committees. Can you pull back the curtain a little bit and tell us about your experience?
Sure. It was a really fun experience. It was a lot of work, but it was one of these opportunities which are probably all too rare to really step back and think more deeply about some of the problems we work on day to day, and to join a group of colleagues, some of whom I knew, some of whom I'd never met before, and really get to know them and appreciate the complementary areas of expertise that different people brought to the table, and to learn from one another, and then to tie that all together into a coherent synthesis was a fun and interesting challenge.
Kiarri, what was it like for you?
Yeah, I mean, I felt a lot of the same experiences around the work and the challenge of synthesizing it, but it was great to work with people across the AHA network. I used the volunteer portal to find people that I hadn't worked with before, and so I feel like that was a nice opportunity to really get these diverse perspectives and bring them together for the statement.
Alka, what was your experience?
So this was my first opportunity to be on a scientific statement, and it was really great just to have different parts that we were all responsible for, really flushing out and bringing the evidence to it, but also meeting the diversity of disciplines that were represented on the panel.
Seth, what was it like?
I mean, the stats update is quite unique. It's been around for a while, so there's very well established kind of process manual and structure that we take, but we're also kind of every year trying to make it better and better and iterating. So it's just it's a very satisfying experience. I had been on the committee for 4 years before I stepped into the kind of chair-elect and then chair role. So I kind of feel like I've grown up on the committee for a while. It's kind of a home for me, and it's just amazing working with the AHA staff and all the other volunteers. It is, as others have said, it is a ton of work, but it's very satisfying at the end of the day because it gets used so much, downloaded millions of times, cited thousands and thousands of times. So it's very satisfying. You feel like it's a lot of work, but it's worth it.
Well, thank you
Yeah.
all for your service on these committees, and I'm looking forward to reading these statements.